I want to start by saying this is one of my least favorite topics to talk about, the discussion around weight. Having been a dietitian for close to almost 8.5 years now, I think it is one of the things that comes up in almost every single session. And one of the things that I have really recognized I need to be sensitive to because there is so much figurative weight held around the literal topic of weight. But my intention for this week's episode is to share with you a little bit more about the stuff that we don't always talk about, which is the science behind weight of a human person. And what I'm hoping that you'll take away from what I'm about to share with you, whether you are a healthcare provider, or I know that I have a lot of science and health science people following me, health and wellness people following me, whether they are other kinds of professionals or they are students or interns coming up the ranks, or if you are just a regular human person who is a patient themselves who goes to the doctor, and this might be a conversation that I think would be beneficial to you. So I hope some of the things resonate with you about the insights and intricacies related to body composition, how weight is also used in healthcare, and also some of the possible root causes that can affect weight in either direction, either positively or negatively, either losses or gains. I always like to share too, as a healthcare provider, but specifically as a registered dietitian, we follow this structure of our patient assessments where we utilize the nutritional aspects of everything to determine whether or not a patient is at risk for something called malnutrition. So I'll talk a little bit more about that later, but the actual word mal meaning poor or bad nutrition. So is somebody at the risk of going hungry, not just in the sense of calories, but also in the sense of the quality of their food. So we'll sometimes start with a screening process of just asking a bunch of questions like, how often do you eat? Where do you eat? Where do you purchase your food? Do you have money to purchase your food? How many, servings of fruits and vegetables do you get? And that sort of thing. And that can give us some insight into a person's habits, but also the resources that are available to them. And then as we meet with our patients over the course of every week or every month or once a year or whatever we are, however we are working with them, whether it's in a true inpatient clinical setting, like in a hospital setting or a long-term care setting or a nursing home, or if like what I do in my private practice where I meet with people more as an outpatient counseling situation where I'm helping them manage and monitor their condition, their situation, that every time we meet, every time I meet with that patient, I'm reassessing them every time. I'm re-asking them questions and I am identifying any areas that might put them at risk or cause harm to them. And I'm also monitoring and evaluating their response to the therapies or the treatments that they have been given. And when I say the word therapy or treatment, it can be a wide variety of things. It could be educating them on what their condition is, what it means. It could be providing them with counseling or support or helping them create things like SMART goals and giving them some insight into their whatever barriers or challenges or obstacles that they might come across, helping them kind of like, overcome all of those things. It could also be medicine. So we could also be monitoring and evaluating how they are dealing with any side effects or any kinds of interactions that their medicines might play against foods or medication to medication, and then comparing that over the course of time. The other thing too is we always prioritize that malnutrition. So as an example, if, I use my mom as a lot of times as examples in these clinical discussions that she has chronic kidney disease. It's later stages, but let's say I'm working with somebody who has stage 3 chronic kidney disease. That's kind of a sweet spot there. So if I'm gathering information at these assessments and they're meeting with me quite regularly, again, my priority is, are they at risk for malnutrition? So I'm less concerned if they tell me something like, I haven't been working out recently, or I'm pretty physically inactive. That's less of an issue for me than if they have absolutely no idea or understanding of what they are eating in order to help manage their condition or at least slow down the progression of it getting worse. And that's really what the outcomes are when it comes to these patient sessions, that we are either helping prevent something from happening at the start of something and providing guidance, education, counseling, resources for that, or we are helping somebody manage a current existing condition or diagnosis, or maybe they have multiple conditions going on, which happens quite frequently. Or, as I said, the third part of that outcome would be slowing things down from getting worse, helping stave off any progression or any exacerbation that might come of that. So that is why we are asking these questions. So when we talk about specifically today's topic about body weight, we're talking about not just stepping on a scale and having your big old meat sack meet the gravitational pull of the earth and then looking at a number and thinking, that is the end all be all. We're really talking about the outside the numerical value of the scale and what that entails in the internal way. We're talking about fat and muscle and fluids and bone and organs, everything, blood too, right? Blood systems, everything within that body is being shown to you as a number on the scale, but it's really hard to figure out what the ratio or the percentages of all of that stuff is. And so that's why I thought it would be kind of interesting to share with you a little bit more about the details of body composition. If you have listened to this podcast previously, I've mentioned, or you've attended any of the webinars or anything that I do, or you know me from school, in addition to being a registered dietitian, I'm also an adjunct professor at Lehman College in the Bronx, where I teach undergraduate and graduate nutrition sciences to my future colleagues or people going into the health and wellness world. And so one of the classes that I've taught in the past is nutrition throughout the life cycle. And what we learn there are a couple of things: that our body tends to be in what we call an anabolic stage, meaning that is building up things that are needed in our body, specifically when it comes to things like bone density and muscle mass. Usually we hit peak density or peak mass at about the age of 25 to 30-ish or so. And so what that means is that at that point, our body's kind of no longer responsible for doing all the heavy lifting, no pun intended. And then it becomes our human responsibility to make sure we are doing things either through eating habits or other health and wellness habits to maintain that density and maintain that muscle mass, that bone density and that muscle mass, or to stop it from deteriorating even further. Because naturally, progressing through our life cycle as we get older, past the ages of 30-ish and above, our body is just engaging in wear and tear and slowly deteriorating. Yes, I know, sad but true. So when it comes to the bone density discussion, this is important because having good, strong bones helps with preventing osteoporosis. That is the porousness of your bones, and thereby reducing the risk of fracturing our bones. That's not the greatest thing to have to deal with and recover from. And I will share this too, that when we're talking specifically about bone density, the vitamins and minerals that are most important, that play the biggest role in that, right? Healthy, strong teeth and bones. When we were growing up, you might have heard things like calcium and vitamin D can help support that density. So if you are looking at the whole foods that you're eating, we have calcium-rich foods like dairy products, milk and cheese, and other types of dairy foods. We also have soybean products like tofu. We also have some plant-based foods as well that have a decent amount of calcium in them, like broccoli and leafy greens. We also have, in the American system, the food system, we have what is known as fortification of foods as well. So one of the examples I like to give is orange juice. Oranges do not naturally contain calcium, or at least not a lot of it. And so you might see different versions of orange juice in the supermarket that you can buy that are fortified with calcium, meaning that the food manufacturer has added in a supplement to that in a food that is not naturally, does not already have that particular item naturally occurring in them. Some of the plant-based foods, though, for calcium are not as what we call bioavailable. So here is where some at-risk groups, like if you are a 100% plant-based person, you're a vegan eater, and you're not eating any animal-containing products, then some of the calcium in your plant-based foods are fine, but you might have to diversify your diet a little bit, or maybe even supplement with an actual pill with a supplement of calcium, because you might not be getting as much in your body if you are eating only the plant-based foods. And by the way, that's just, I want to clarify that, because I think if I heard correctly, I think like bok choy is pretty good and pretty bioavailable. So there could be certain produce-based items that are good when it comes to absorption of calcium, but we always try to err on the side of caution. if you're curious or concerned, obviously speak to your doctor and make sure that you're getting tested for that. Vitamin D is the other thing that comes up a lot. Vitamin D is a vitamin. Obviously, it's part of the micronutrients category, and it is very much available in the sun. So if you happen to be outdoors for about 10 minutes a day, you probably get enough vitamin D to do what it needs to do in your body. If you are looking to get it through foods, you can get it through what we call oily or fatty fish like tuna and salmon and sardines and mackerel. You can also get it through egg yolks, and you can also get that through fortified foods as well. So the at-risk groups there too would be, as far as vitamin D is concerned, would be people who have darkly pigmented skin because it's a little hard for the sun to penetrate through that. Anybody who might be housebound, like the frail elderly or people in care homes who are maybe immobile or not able to move around outdoors. Again, I would hope that they would be taken outside for some fresh air, but I don't know and I can't judge. Also, anybody who wears clothes that cover a lot of the areas of their body. So this might be something like in the religious world, a lot of people adhere to certain dress codes. So again, if you're outside and you're covered up, you might not be getting sun penetrating your skin as much as others. Also, I mean, a lot of us just live and work indoors constantly. We barely get outside for much of anything. So that is something to consider as well. And then postmenopausal people. So estrogen plays a role in bone strength and bone density. So as we lose estrogen, as we age, as we become menopausal, then that can end up putting us at risk for things like osteoporosis as well. And vitamin D, so like I said, some of the plant-based foods or the fortified foods or the sun, not as much of an issue if you are following a plant-based diet or are vegan than maybe some of the other vitamins and minerals that would be there. So I think as long as you have a pretty good, well-rounded, diverse diet, get out in the sun every so often, you should be okay with managing your bone density. When it comes to the muscle mass discussion, so maintaining muscle, we need our muscles to help us with maintaining and managing our mobility, our metabolic health, and our overall strength, the ability to lift ourselves up off of something or be able to move our limbs. Obviously, for anybody who has physical disabilities or physical limitations, you probably will still be working with some sort of occupational or physical therapist to help move around to get the circulation in, because again, we don't want people suffering from malnutrition, and muscle mass plays a huge role when it comes to assessing malnutrition. When we get older in the later stages of our life, in the later decades of our life, our body naturally decreases its bone density and its muscle mass, and it naturally increases our body fat. And this is where I think the discussion around weight comes in, especially in the clinical or healthcare settings. When we're looking at research, and I'll go a little bit deeper about this in a second, when we're looking at research, we're noticing that what we call the excess body fat or fat mass, especially around what are known as your visceral organs. So your viscera is kind of like this abdominal region, and the fat that's carried, we need fat. We need fat for a lot of things, to protect us and for temperature control and for synthesizing hormones. Obviously, we need fat to exist in our body, but if there's an excess amount of it, and I'll give you a definition of what that is shortly, then it can affect the heart, the lung, the kidneys, the liver. There could be issues there, and it can also overall increase risk of chronic conditions. The muscle mass, if that is deteriorating, again, what I mentioned earlier with, maintaining muscle mobility, maintaining strength, it also prevents us from damaging our bones. So if we are at risk for falls and don't want to have fractures, then having that adequate muscle mass would be quite important. I always like to do a little quick pop quiz when I share information about this. So if you are listening to this episode right now, if you have the ability, or you're watching it on YouTube, if you have the ability to send a little note or comment, if you want to take a guess at what things are important with building or maintaining muscle mass, I'll give you a second to think about that. What comes to mind for you when you hear things like muscle mass, body muscles? TikTok. Protein for sure. That's one of them. That's one of the macronutrients that we eat to give us calories and also to help with repairing our muscle tears when we're moving around and also maintain adequate muscle mass. And strength training. Strength training, my friends. Everybody's so focused all the time on cardio. I think if you go back to one of the last episodes where I was interviewing Ashley Harpst, we talked about this too, because she does sports dietetics and sports nutrition. And we talk about how everybody's so focused on cardio all the time. And we kind of sometimes put the strength training off on the side. So highly recommend with medical clearance that you are incorporating some sort of strength training, resistance training, weight bearing exercises as often as you possibly can. Even lifting heavy groceries up and down the stairs is adequate. Laundry, whatever it is that you're lifting something and maintaining that muscle mass, it's very important. Aside from stepping on a scale and getting a weight from you there, sometimes in the clinical settings, we'll do some other things that we can assess and measure. One of the things, especially if you are chair bound, we'll do something called a mid-upper arm circumference, where we literally put a tape measure around the part of your arm between your shoulder and your elbow, and that helps us get an understanding of the muscle mass or the frame in that sense, to see if we compare that on a chart. We have other things called, I don't think I've ever used this, but something called bioelectrical impedance analysis, BIA. And we also have something, and I'm going to mess up this name because I do it all the time, the dual energy X-ray absorptiometry scan, also known as a DEXA scan. So you might have heard that before. So here's the thing with DEXA scans. They are known as the gold standard. Gold standard just basically means the most accurate form or the best in practice to use to measure and assess our body composition. And the DEXA scan itself is kind of like an open MRI looking thing. I believe you lay down in it and you get sent. I've never been in one, and you get sent through it, or it scans up and down on its own. The equipment kind of rides up and down and scans your body. And this can give a true reading of a wide variety of things underneath all, and not just related to stepping on a scale. So this can give a good read as to organ weight and bone density and the things that we talked about before. However, even though some medical facilities do have DEXA scans available, and some hospitals do, and some other imaging or diagnostic centers like a radiology center probably has one too, they're usually not covered by insurance, I'm sorry to say. So if you would like to learn a little bit more about this, speak with your healthcare provider. If you fall into one of the following categories, you could get a referral, or maybe, depending on your insurance, maybe they will consider it to be medically necessary if you are a female aged 65 years or older, because anytime we would consider that to probably be also in the area of postmenopausal, or you are postmenopausal under the age of 65. With the decrease of estrogen comes the increased risk of bone density issues, so that could put you at a higher risk category. So you might want to consider getting a DEXA scan there. Men age 70 and older, again, as we age increase, we decrease in the muscle mass and in the bone density, so that might be an indicator of making sure you're assessing things before it gets worse. If you have a history of fractures, or you've broken bones before, and if you are currently dealing with a condition or a treatment that could affect your bone health. So if you have rheumatoid arthritis, if you are dealing with chronic kidney disease, if you are taking steroids, these things can also put your bone density at risk. Other risk factors that could impact bone density and might be an option for you to get a DEXA scan could be if you have a family history of these types of issues, if you are an excessive alcohol drinker, if you are a regular smoker, and if you have a low body weight. So we'll talk a little bit too in a second about what body weight even means, how we're going to define that. But if you are on the lower end of body weight, or you have lost a significant amount of weight in kind of like a critical care setting, then that could be impacting too, because again, you're probably losing muscle mass. Your bones are becoming less dense as that is, and you want to be keeping an eye on them. One of the things I tend to say too, like if we're in a clinical care setting and I was trying to keep you alive, I would need to know how many calories to feed you. And those equations are based on a variety of different things. We have your height, we have your weight, we have your gender, we have your physical activity levels, or sometimes what are known as your stress levels. If you are bedridden or if you are very, very active, we accommodate that accordingly, both with your calories, or what is known as your energy, and also with your protein needs, because again, we're trying to maintain your muscle mass. We also sometimes rely on something called the Hamwe method for ideal body weight. So here's where I'm going to stop and just share with you a few things, me and my controversial takes on all this stuff. But in the textbooks, this is what we're given when we're learning things like this. We have a formula that's based on a certain amount of pounds per height for males and for females. And so an example that I did here behind the scenes is I have a 6 foot tall male. And when I do my calculation, the quote unquote ideal body weight for a 6 foot tall male is 178 pounds. If we're looking at that in metric, that's about 82-ish or so kilos. For a female, I put in my little calculation example here, 5 feet, 5 inches tall. That's about the average-ish or so female height. And then when I do the weight calculation, I come out with 125 pounds for ideal body weight. In the conversion for metric, that's about 54 or so kilos. So, my friends, just because something's ideal doesn't mean it's realistic. And I will absolutely admit here out loud that I'm about 5 feet 4 inches tall or so, and I've probably been staying or maintaining about 140 pounds of weight for the last like 20 years or something. Now, body composition wise, I've shifted, but that number on the scale is the thing that holds steady. So, this is why, again, I kind of encourage people not to focus so much on that number because what's happening underneath it all is going to be quite different. But my point about this is that if I were to look at that ideal body weight calculation, that it's going to send information back to me or to my healthcare provider that I should be at about 115, 18, or 20 pounds for my height. I don't think I've been that weight since I was like 11 years old or something, very, very young. And also, if I tried to be 15 to 20 pounds lighter now, it would take a significant amount of time, especially because I'm at an age, I'm menopausal, but also my body is at rest at this maintenance weight. And so I will have to be actively trying to keep it at 20 pounds less for the rest of my life. And I just don't think that is realistic or sustainable. So we're going to talk a little bit more about that too. But I thought that was an interesting thing to share with you because of the fact that if you're walking into a doctor's office and they're looking up things and they're giving you your information and they're weighing and measuring you, and then they're telling you, according to this particular calculation, what you should be, that might not be realistic. And going a little bit deeper into that, why? Because body weight is influenced by a variety of things. It's influenced by genetics, it's influenced by metabolism, it's influenced by an environment, psychology. We've talked a lot about the social determinants of health as well, of what helps people stay healthy if you have access and resources to a wide variety of things, or if you don't. So, not only that, but also what I found kind of interesting too, in one of the other classes that I've taught in the past, where we've taken kind of like a world foods tour. So I taught food society and health, and we take a look at the global concept of health and wellness across the world. And some cultures just naturally have a preference or favor certain body weights or sizes that they deem correlate to a wide variety of things, not just nutritional status, but also a wide variety of things. So thankfully at Lehman College, I have such a diverse student population that they have given me feedback and shared some of their lived experiences that confirm what I'm about to tell you. As an example, Shanghai, if we look at Shanghai, they expect their females, their women, to be small and slight and slim because it kind of exudes femininity and daintiness and being demure in that sense. Where in contrast, someplace like Jamaica, as an example, they like to have meat on their bones because being bigger and more round, having a more rounded body shape, indicates things like strength and power and financial status and fertility. So when we solely focus on the discussion around weight and this whole thing about ideal, and I'll talk a little bit more about the ideal discussion shortly, we are really then attacking someone's identity too. So if we're asking somebody to be an ideal weight range and we're either asking them to be higher or lower weight than they currently are, this can affect a variety of things, emotions, etc., and also potentially affect how in their culture they look at things. Just like we've talked about cultural food ways and traditional meals and how, rice as an example is a global staple food. I'm not going to tell somebody never to eat rice again. We modify a few things, but we try to also be really sensitive as to what is the identity of a person, of a culture, or of within their personal framework. So that's something I just thought I would share with you. That is a takeaway. Whether you are currently a healthcare provider, somebody who's looking to become a healthcare provider, or part of the general population where you are a patient who has had conversations like this with your healthcare providers, I'm hoping that's a good takeaway. When it comes to the pediatric population, and this spans the ages of 0 to 20 years old, we will plot on a growth chart, the progression of a child as they're growing. The information that we're using and how we're assessing and measuring them is then converted into what we call percentiles. And what we're looking for is a pretty, nice progression, what we expect on a growth curve. Obviously, there could be growth spurts, or it might be a time where somebody's caught a cold, gotten sick, and didn't eat. So there's a little bit of a dip. But we're looking for patterns, because patterns then, if we see very large, long sustaining spikes or drops in that plotting of their growth charts, and that is for weight, length, and age, then it could indicate, again, that nutritional risk factor, or even things like cognitive or motor skill functions that might need to be addressed or looked at a little bit further. When we get past that pediatric stage and we're now entering into adulthood, we now use these categories or these measurements known as body mass index. I'm sure that that is something that is very familiar to you, or what is the acronym BMI. And the classifications for BMI are underweight, healthy weight, overweight, and then classifications in stages of obesity. The term obesity is sometimes a bit of a sensitive conversation. I'll talk a little bit more about that too. The criteria that we use to calculate somebody's BMI in order to plug in the classification of these categories I just mentioned is solely based on height and weight. That is it. So it is not a perfect, in fact, it's quite a flawed type of approach. And I am going to give you my personal opinion about this too, because I'm part of the new generation of dietitians, and I'm very grateful for a lot of the things that are being questioned in our medical profession and the healthcare world of how we utilize certain tools that don't necessarily assess people as much as we thought that they would. So in the case of the BMI classification, if you are underweight, this is, again, based on height and weight only. It doesn't necessarily take into account the things that we just mentioned before. It doesn't take into account body composition in total. It doesn't take into account race or ethnicity, and also age. In fact, what we have come to see and to learn is that the older adult population, ages 65 and older, actually fare better, have better outcomes, health outcomes, and have lower risk of chronic conditions and premature deaths if they are hovering around that quote unquote overweight category. So as a healthcare provider, if I'm just looking at a patient's chart and it gives me their height and their weight and their BMI classification, but I see that their age is 65 or older, if they skew in and get charted as an overweight category, I actually look at that more like I curve it down, like it's a normal or healthy weight category for them. So this is something important too. If you are a care provider for somebody who is older, like a parent, or if you are of that age too, that is something to consider too. If you find out what your BMI is and your healthcare provider is classifying you incorrectly, that's a time to inquire with them and say, did you know that in fact, that puts me at a healthier weight for me to have, right, a little bit more meat on my bones as I'm aging, because again, as we age, we decrease, or our body's just naturally going through wear and tear. This helps us offset this a little bit. Not to mention, oh boy, here we go. So I'm going to start with this controversial discussion, and you know what, I might just go into a deep dive later on, but you can do tons of research on your own if you want to. Body mass index is rooted in what is known as eugenics. So that's not a great conversation to have. And it's also invented by somebody who has nothing to do with healthcare. So why is it still used widely in the medical community? Well, because it's an inexpensive and pretty quick way to analyze, just get a quick and dirty look at somebody's potential health status and outcomes. But my friends, I have talked to many healthcare providers, and my students, I teach them this as well. It's lazy medicine just to look at BMI and immediately correlate it to something one-to-one ratio thing. Like it's just not good. So I really want to empower you too, if you're listening to this, to just make sure that people are looking at a wide variety of other things and not just solely focusing on that body mass index. Because also, if I go a little bit more into detail, especially this term of obesity, if I'm looking at it from the BMI standpoint, we're just looking, like I said, height and weight. Height and weight gives you a number, and that number is categorized as whatever I just mentioned: underweight, healthy, overweight, or obese. Right, so that is obesity. A BMI of 30 or higher equals obesity. But obesity is technically also defined as excessive body fat of either more than 25% for males and more than 30% for females. Okay, well, you just told me it's just height and weight. And if I step on a scale, you're not exactly assessing my body fat. So which one is it? Is it BMI Or is it body fat? Oh, it's both. Oh, you know what? It's also a third thing too. Obesity is also defined as having a waist circumference, what we call abdominal adiposity or central adiposity, a waist circumference of greater than 40 inches for males and greater than 35 inches for females. So again, this is why a variety of different measurements or indicators are important because it's a very nuanced approach, nuanced insight into understanding people's body composition and what that even means. So I'll give you an example. You can't see this because I'm looking at a screen right now of an image that I love referring to when I have this discussion. But if you have attended or will be watching any of the recordings on the YouTube channel, we have a whole thing about the science of weight too. So you can check out the image I'm about to describe to you here. Picture in your mind a sumo wrestler and a competitive bodybuilder. All right, both of these people are 6 feet tall. Both of these people weigh 250 pounds. In the BMI calculation, they both come out with a BMI of 33.9, which is technically classified as obese. So, socially speaking, right, my social construct tells me, oh, the person who is the competitive bodybuilder is probably healthier because they're in a leaner, fitter body and they're lifting weights and that sort of thing. Not necessarily. In the example I'm giving here, these two people are in very qualified, heavily trained, competitive, performance athletic situations. So I could argue they probably do a lot of stuff that you and I don't do on a normal basis when it comes to physical activity. That's number one. Number two, just because somebody is leaner, less body fat, and more muscle mass isn't also necessarily going to be equivalent to metabolic health or even physical health too. We see sometimes that competitive bodybuilders or people who do a lot to maintain that excess muscle mass and reduce their body fat, they end up with tendonitis or tendon pains. And because they are not carrying enough body fat on them, they also have hormonal issues or reproductive health issues because we need, like I said earlier, that we need a certain amount of body fat in order to help us metabolize and synthesize certain things that our body needs. I will also say, and I'll share this in a second coming up, that we have some research that I'm happy to share with you to admit that yes, there are correlations, but we see them on opposite ends of the spectrum. So when it comes to weight as a predictor of health, and if you've heard me talk about these things before, you know that I always say, how do you define health? Health is defined as a myriad ways. So what is it to be healthy? Well, if you're talking about just the overall increased risk of chronic condition and premature death, somebody who has a BMI on the low end of an underweight category is just as likely to have, statistically speaking, the same risk of chronic conditions or premature death as somebody in the obese category. And yet, I think you would agree with me, we don't really see a lot of discussion about the underweight people, do we? Everything that we see in media, everything on commercials, everything even in our medical textbooks have chapters upon chapters and messages upon messages about how we address the obesity discussion and not really focused on anyone who is also at risk, but on the other end of the spectrum. Not so great. All right, number two, when it comes to the predictors of health, if you, again, you're having these conversations with your doctor, if you are on the higher end of things, if you are carrying some excess body weight, especially around certain areas of your body, that you don't necessarily have to go too far to get out of the danger zone if there is a correlation with danger zone being there, whether it's cholesterol issues or blood pressure issues or heart disease or type 2 diabetes, whatever. Just as little as maybe a 5 to 10% reduction in your starting weight can be associated with decreasing that risk or having things kind of, again, come out of that danger zone. That's what's known as a therapeutic approach. So you don't have to necessarily force yourself to go into these extreme restrictive diets to meet a quote unquote ideal body weight or body size, just chipping a little bit away. So again, if you're feeling like you're being forced or talked to by your doctors that they want you to hit this potential number that just feels like you're never going to get there, even so much as 5 to 10% might be okay for now. And then you decide how long that might take you and what you're going to do to get there. But I will keep saying that the weight discussion around the prediction of health is not the sole tool that should be used. Diagnostically, it should not be. All right, let me share with you some other things that I found as I was researching this topic too. So back in 2016, about 1,000 medical professionals, both doctors and nurses, healthcare providers, I think a variety of them were in there too, were surveyed, and about 40 to 50% admitted that they did have negative feelings about people in larger size bodies or heavier weight bodies. When that happens, that is known as something called weight bias or weight stigma or weight discrimination, and that leads to unfair treatment of our patients. It means that those healthcare providers are less likely to spend time with people in larger size bodies in session. They're less likely to develop an emotional rapport or help support somebody because they're putting the onus specifically on the person to quote unquote get better or get healthier. And they might even deny treatment either through their bias or because there are no other accommodations being made for somebody who might not be able to fit into a piece of equipment or a diagnostic tool or an exam. Or, like in the case of something like an elective surgery, like a knee surgery, a doctor might say, I can't perform that surgery on you until you've lost the weight. So, again, how much time goes by before you can meet that goal of what the doctor is setting up for you? There's also a big over prescription of weight loss as treatment. So again, really no pun intended, but weighing out your options here and talking to your doctors about what the concerns that you have are and what the maybe getting a second opinion from somebody who might be a little bit more qualified or has the equipment for you to be diagnosed properly without you having to wait and wait and wait before you meet that weight loss number. The other thing about this is that if, regardless of what end you're on, if you're trying to gain or lose weight, but usually it's mostly losing weight because that's the focus of a lot of the American discussions, this ends up happening a lot too, where there's something called yo-yo dieting or weight cycling. And weight cycling is when you are on these repeated cycles of losses and gains. One of the last conversations I had with somebody about this said, well, how much and how often is it before it's an issue? And I don't know the answer to that. I don't know if it's many times over many years that you've tried to lose 25 pounds and then gained it all back again. Like I gave myself as an example before, your body might have a nice set point and you're forcing it to hit another number, but it's going to keep bouncing back to something else. Or you are taking unsuccessful, unsustainable, and unrealistic approaches to lose or gain that weight. And then your body is reacting after you are no longer able to sustain that. So whether it's restrictive dieting or excessive exercising, it's just not physically possible for you to keep that up. And because of that, cycling over and over, lose and gain, right? Beach body ready. My daughter's getting married in October. New year, new you in the healthy, living part of the first of the new year. These are my resolutions. By doing that over and over again, what ends up happening is that that also increases a lot of negative health implications. So there could be thyroid issues, hormonal issues, and also putting you more at risk for chronic conditions. The things that you were trying to get away from by potentially trying to meet these goals. Additionally, there's a lot of triggers that can happen there. If you go back to one of the earlier episodes that I had with Amelia Sherry, she is a fellow dietitian. We talked about earlier stages of body image discussions with children, specifically daughters, because that's her focus on that. But the negative talk, the negative criticism, and if you are prone to that, then that affects your self-esteem, that affects your confidence, that gives you shame, that makes you be dissatisfied with your body. And that ends up leading to things like disordered eating patterns. And as a healthcare provider, I don't want to know that what I said to you gave you an eating disorder. I don't want that to happen. Not only that, but I would also assume and probably feel hard pressed to be pretty sure about this, that if it was the way that our conversations were happening in our sessions together that caused you to have that dissatisfaction, that shame, and potentially have a disordered eating relationship with food, how likely are you to come back to me? Probably not. So I'm doing more harm than good, and my oath as a healthcare provider is to do no harm. One of the things I like to share when I have this conversation with people is this approach or these principles known as the health at every size approach. Not healthy at every size, because some people out there who hear this language and end up saying things like, you're glorifying obesity. That is not the point of this. The point of health at every size, meaning that no matter what size a person is, healthcare is hopefully, it will continue to be a human right for people of every shape and size. And it is also to be provided under conditions that are free from bias, anti-fat bias specifically, but really all sizes the bias-free conditions, and that it should reflect the values of what we hope to be overall healing and care and gracious support, and recognizing that health in general is just a very deeply personal discussion. We want to make sure that we are meeting people where they're at and creating a patient-centered approach. So if you have felt uncomfortable in some of your doctor's visits, or when you go to have any doctor's visit, any office visit, they immediately stick you on a scale, you can decline that. You can absolutely say no, thank you, or you can be honest if you want to share more about what your concerns are. I don't need to be weighed. I decline to be weighed. It makes me uncomfortable to be weighed. Or if they're insistent, or I'll get to in a second, I'll share why sometimes it might be medically necessary to do so. You can just turn around, walk backwards on the scale, or tell them not to share the number with you because you'd rather not know if that's something that bothers you. On the provider's end, we just make a note of that. Patient declines to be weighed. That's it. We're done. No problem. You can also check to see if your healthcare provider, especially somebody like me who's a dietitian, if they take a weight inclusive versus a weight normative approach. A weight inclusive approach will assume that patients are able to share their lived experience with us and that their well-being is independent of just the weight. So there is the challenge of the belief of that BMI discussion, like I mentioned before, that BMI is not just specifically related to health status, or even worse, moral character, right? Let's not even get into that. And that we minimize that stigma. So a weight normative approach is doing all the other stuff. It's making you feel a little bit uncomfortable in those situations, that there's a personal responsibility forced upon you, aka healthism, which we've talked about before in a lot of these discussions and these episodes, that they focus on weight loss only. Like before you even walk in or you tell them you have a cold or a broken elbow, it's like, go lose 30 pounds without even giving you any other guidance, or again, utilizing that more nuanced approach of what we want, and that believing that a higher body mass index is going to automatically equate poor health, which we know not to be the case. In fact, there is a lot of research done on this. And just like I said before, with the triggers that can also exacerbate someone's situation, not just health, but mentally, like putting somebody through that mental anguish, that they're less likely to come back. So you're not really, it's not really giving you the proper result you want it to be. I mean, it's possible somebody will come back to me because I scared them to do that. But again, how consistent and how realistic and how sustainable is that whole approach going to take? I don't want to have that be an issue. So now I'm going to share with you when it might be medically necessary to have your weight be done. And again, you can still totally not look at the scale or turn backwards on this if you want to, or share with your healthcare provider you're uncomfortable in hearing the weight. But if you are under certain medication or anesthesia for some surgeries, they might have to weigh you for that to understand a little bit better about the dosing. If you are pregnant and going through the stages of pregnancy, there's a lot to be monitored there. You have the fetal weight, you have the placenta, you have the amniotic fluid, you have the breast tissue, you have the blood system, the fat, the nutritional stores. So even if you are getting pregnant at an already existing higher body weight, higher BMI, based on what, most of the offices are going to have for you on the chart, you still have to gain weight. You still have to have your weight monitored. You still have to make sure that you are progressing healthily, correctly through the whole pregnancy. Also, if you are in specifically, I would say inpatient eating disorder recovery, most likely they're going to weigh you as well, because that would be an indicator with, especially with the muscle mass and bone density issues, are probably going to have you go through some assessments, regular assessments. So that could be a very, very tricky, triggering, and sensitive situation there. And lastly, we're talking about if you are dealing with treatment for or conditions related to congestive heart failure, kidney failure, there are fluid shifts that can happen. So two of the terms that I use are edema. This might be a word that you've heard before. Edema is just the fluid building up in your body. Sometimes it's more around the ankles, like it pools around the ankles, and swollen ankles, swollen legs, swollen feet, but it can happen really anywhere. And ascites. Ascites is a little bit more in the abdominal region. Again, an indication of, is this person retaining water? Are they unable to shed that? Is this going to cause more of an issue, exacerbating something like the heart, the liver, the kidneys, the lungs? Because then that would be weighing and measuring. And when we do this in the clinical setting, we are looking at very specific time frames. So say you're inpatient, or you come back for visits every 3 months or whatever, if you're in an outpatient setting, maybe week by week, month by month, and over the course of 6 months, right? We're looking at plus or minus 5%, more than 7.5% in a certain amount of time, that would indicate a significant or severe change in body weight. This is involuntary. Like you're not trying to be on a diet, you're not trying to eat more and gain weight. Your body is going through these fluid shifts or these restrictions that are happening internally that are potentially putting you more at risk. So that is where we would be documenting that and seeing how we need to address it. In the non-clinical way, things that can change your body weight from day to day and week to week, which is why, listen, if you're the type of person that weighs yourself, okay, fine, I'm not going to stop you from doing that. In an ideal world, throw out your scale. But I usually tell people don't weigh yourself every single day, every single morning. Weigh yourself maybe once a week. It's more about the patterns and the differences over the longer periods of time because every day is a wide variety of different circumstances. You could either have had a really salty meal the night before and now you're retaining water and you're feeling dry and parched and bloated, and that could be about 2 to 4 pounds difference on a scale. And if you're really being critical about the amount that you weigh, not realizing again fluid shifts, etc., that might be a little mentally frustrating for you. Also, excess carbs and excess calories. Yeah, calories in, calories out. We hear that all the time. And there's some truth to that. Like if I'm eating a lot more than I'm burning, then my body's like, what do I do with this extra stuff? Oh, I know. I'm going to package it into triglycerides and shove it into all the little body fat areas. And boom, there's another 2 to 4 pounds in the course of a day or a week or whatever. Alcohol consumption, that's a big one too, especially when it comes to liver. So if you are drinking alcohol excessively, then in that case, obviously, I would say please be careful with that because not only can it cause liver issues, but it can also cause cancer. So the alcohol consumption itself could put some weight on you because it is what we call, these empty calories, menstrual cycle, hormone fluctuations, medications that have side effects of putting weight on, bowel habits. I mean, if you're putting things in and nothing's coming out, that could be another 4 pounds of fecal matter sitting in there. So please, in that case, make sure that you are keeping regular by making sure you're eating enough fiber and drinking enough fluid and trying to go at the very least every few days consistently. Daily would be better. Maybe even twice a day would be better. But if you're backed up a little bit, then, consider going and getting maybe a stool softener or a laxative or speaking to a healthcare professional if it is more of a serious situation. My whole point about this, though, is that poop can build up and cause you to have a little bit of excess weight, and you'll have to wait until it comes out before you can weigh yourself again and feel like you're back on track with whatever your approach is there. Caloric restriction, fasting, intermittent fasting, people who do religious fasting as well. So yeah, of course, if you're eating less calories, you're taking in less calories over a certain day or many days, then or you're burning more calories than you're eating, then yeah, that could be causing a change in body weight. And again, this might be something that is voluntarily something that you do to maintain or manage your weight. Or if you're exercising and you're sweating, or you're sweating just profusely by being outdoors, carrying stuff up a hill or walking out in the hot sun, that sweat is coming out, and that could be water weight or that could be fat loss as well. So those are things that could potentially have causes some changes in your body weight too. I would like to see if you have any feedback for me. I always ask this at the outro to share with me any of that. But what are your thoughts about things like this? Like, are you the type of person who's very focused on managing their weight? Are you dealing, and you don't have to obviously divulge any personal private information, but are you dealing with certain conditions where you are being weighed and measured? And is that taking a toll on you? Do you feel like you want to have conversations with your doctors or your healthcare providers? Are you somebody who has had some not so great relationships with food or disordered eating patterns where that is an issue too, and you are trying to get back to a more, quote unquote, healthy weight for you? Are you wanting to work with a healthcare provider that does take a more weight inclusive or weight neutral approach? These are things that I just want you to take into account and think about. Or if you are, as I think I said earlier, a care provider to somebody, maybe these are now questions that you can bring to your doctor's visits and get a better understanding of what's going on behind the scenes there when they do ask you to get on the scale or when they share with you information about body weight, body changes, and body composition.